I am Dr Ashwini Sharma. I will be talking about Colles fracture today. Starting with definition of Colles fracture. Colles fracture is the fracture of distal end of radius 3/4 of to 1 inch from the distal articular surface at the cortiocancellous junction. The Colles fracture is named after Abraham Colles, who described this fracture. Along with fracture of distal end of radius, Colles fracture can involve the fracture of the ulnar styloid, dislocation of inferior ulnar joint, along with fracture of distal radius. This fracture is common in postmenopausal elderly females, that is, where the menstrual cycle has stopped. Because of the postmenopausal stage, there is osteoporosis. And the second age group where this fracture is common is the young adult male who go outside because of road traffic accident, they get this fracture. Coming to the clinical features, whether this is road traffic accident or a fall at home, this is fracture of distal radius. So most commonly we come across elderly females, distal end of radius, they are walking in their home, they fall on outstretched hand. So once they fall, because of osteoporosis, they get this fracture. Like anywhere else, the signs and symptoms are pain, swelling and deformity. So patient comes to us after history of fall or roadside accident. You have pain, swelling and deformity around the wrist joint. And there may be, in some cases, there may be carpal tunnel syndrome, tingling in the hand. And the deformity which is present because the displacement in Colles fracture is dorsal displacement. The fragment is going posteriorly, but deformity is real fork deformity. Shape of the needle fork is the shape of the wrist. So coming to, after you have examined the patient in emergency department, pain, swelling, deformity, we come to the X-rays, X-ray of the wrist joint. If you look at the normal X-ray, this is AP view and this is lateral view. So in normal X-ray, the articular surface of distal radius looks downwards, ulnarwards. And if you look at the relation of the two styloids, that is the ulnar styloid and radial styloid is at a lower level as compared to the ulnar styloid, and this is by 1.2 centimeters. The radial styloid is at a lower level. So this normal relation you should know, so that when you look at the abnormal X-rays, you can make out. So this is you can see this is the relation of the distal fragment. You can see here they are at the same level because of the displacement. So coming to displacements, you have 6 displacements: dorsal displacement, dorsal tilt; lateral displacement, lateral tilt. So when the fragment goes dorsally or posteriorly, you call it dorsal displacement. Also there is angulation or tilt. When the fragment goes laterally, you call it lateral displacement along with tilt. So impaction, this is impaction. You can see both the fragments are impacted into each other. Supination is the 6th deformity. So these are the deformities which you should be looking for, and depending upon you decide the deformities and then you correct them while you are reducing this fracture. Just one more point, other fractures which can occur with fall outside hand: fracture of humerus in children, dislocation of elbow and shoulder, this can occur in children and adults both, and scaphoid fracture. You can see these are the fall on outstretched hand. Along with Colles fracture, these injuries can occur in a patient who falls on outstretched hand. This is X-ray of wrist with hand, anterior posterior view. You can see the bones of the forearm. This is radius, this is ulna, and then you have two rows of the carpal bones, proximal row and distal row. Proximal row you have scaphoid, lunate, trochanteral and pisiform. Overlapping is pisiform. Then you have trapezium, trapezoid, capitate and hamate in the distal row. These are the metacarpal bones. These are the phalanges of the finger. So metacarpals you count from thumb 1, 2, 3 and 4 and 5. And then phalanges, you have 2 phalanges in the thumb and 3 phalanges each in the fingers. Now coming to the Colles fracture, this is the cortical bone and this is the cancellous bone. This is junction of the cortico-cancellous bone, and this is the Colles fracture, the site of Colles fracture. Lateral view. Lateral view of the wrist joint. You can see once again this is the Colles fracture. There is fracture of the distal radius, and you can see the displacement, that is this distal fragment is going posteriorly. This is the anterior side, this is the posterior side. You can see the shadow of the thumb metacarpal, this is on the anterior side. So this distal fragment is going posterior, displaced posteriorly as well as tilted posteriorly. So coming to treatment of Colles fracture, the principles of treatment anywhere in orthopedics are traction and counter traction. So one person is pulling the elbow, the other person is pulling the fingers and the thumb, and the surgeon is doing the reduction. So traction and counter traction. So you know the displacements dorsally and laterally. So you apply traction and counter traction in palmar flexion and ulnar deviation. So the hand goes down and ulnarwards towards the ulna, and then you, with traction on, you apply the plaster. The extent of plaster is from below elbow to just sort of knuckles. So extent of plaster is from below elbow to just short of knuckles. Position is palm flexion and ulnar deviation, and you call this plaster is Colles plaster. Name once again the name of the person, Abraham Colles. So this has to be done under general anesthesia. That is the person is under the effect of anesthetics, and you do it under the IITV, that is image intensifier. The patient is under the effect of anesthetics, and we use television, that is we are taking X-rays simultaneously at the same time, and the real-time TV gives us the position of the fragments, and then you reduce the fracture and apply the Colles plaster. If you feel the fracture is unstable, then you can apply the Kirshner wires, that is K wires. So plus minus means either you can use K wires or you cannot use them. And then in young patients, maybe you can use volar plate also, that is you apply plate on the volar side of the radius, distal radius. So this is open reduction, and this is here we are doing claw reduction and percutaneous fixation. Coming to complications of this fracture, the fracture itself is very common. Malunion is the commonest complication of the Colles fracture. That is, even if you do claw reduction or K-wire fixation, malunion will occur in some patients, and the deformity is dinner fork deformity, because fragment goes posteriorly. So deformity, as already discussed, is dinner fork deformity. And in some patients, if malunion occurs, and if malunion is symptomatic, say patient is young laborer, so you do corrective osteotomy. So you do an osteotomy of the malpositioned fragments, and then you do the osteotomy of the distal radius, and then you apply plate, or you can fix with K wires. So osteotomy is corrective osteotomy. You displaced malunited Colles fracture, and then you correct it with osteotomy and apply K wires or plates. CRPS is complex regional pain syndrome. Already discussed that fracture is common in elderly females. These females are anxious. So this complication is more common in females because you apply plaster, then they don't do physiotherapy. You ask them to move the fingers, they will not do the physiotherapy, and then they will have tapering, swollen fingers with pain. This is complex regional pain syndrome. And this is, you don't know the exact cause why this occurs in some females, why it doesn't occur in some others. But this is difficult to treat. Analgesics, physiotherapy, gabapentin, pregabalin, all have been tried. And if the patient doesn't respond, the pain is very severe, you can apply you have a ganglion here, stellate ganglion, so you can block that ganglion. Anesthetists, they do it, they'll put lignocaine there, and that ganglion that will help us in pain relief rather. Another complication is head shoulder syndrome. You apply plaster in hand and the patient doesn't do exercise. Whenever we apply Colles plaster, we ask them to move elbow, we ask them to do shoulder abduction, right? So if they don't do exercises, they'll get stiffness in the shoulder, also stiffness in the hand. So because this problem is with both hand and shoulder, stiffness of this is called hand-shoulder syndrome. Treatment is simple physiotherapy. At the start of the treatment, you ask them for physiotherapy. Another complication is EPL rupture. We have tendon of extensor pollicis longus. This is tendon of EPL, that is extensor pollicis longus. So if the fragments are malpositioned, so this tendon will always rub against the fragments and it will rupture. They call it drummer palsy because drummers, they use it while they beat the drum. So because this tendon is important for them, so they also get this tendon rupture. So this is also called drummer's palsy. And another complication is carpal tunnel syndrome. You have median nerve in front of the radius, so that median nerve is also compressed in carpal tunnel. So you can see once the median nerve is compressed, this is called carpal tunnel syndrome. And treatment is, if the patient is symptomatic, treatment is decompression and release of the flexor retinaculum. Thank you very much.